Here. You guys hear me okay? Awesome. Yeah, it was actually, I hope Yami does join because I was thinking back and I did this social networks and health workshop myself back in 2016 and was together with Yami. And then we both had support through this mechanism to go to the network analysis conference in Beijing. And we were buddies there and we talked about network science and we talked about postdocs and her career development award. And all of it was really formative. So I hope we're able to connect, but I'll give a recap of the work that I shared and happy to talk about any questions that come up and lessons learned and thoughts about the process as well as the findings. So in my presentation, I talked about two different projects that I've been really closely involved with. And the first one was a study that I was involved with led by Susan Maman, and that was with the groups, the networks of young men in Tanzania. And she did not go into this work with a networks thinking at all. She, had previously been doing work on HIV with women, realized that, was kind of early on in making the association between interpartner violence and HIV risk among women, and did a lot of work. She's really more a qualitative person or a mixed methods scholar, and realized she needed to reach men in order to do some intervening. And so she did this community mapping and really had no idea where to find young men because they weren't, the age we were looking for, they weren't in school. And unemployment is so high, they weren't at work, so no workforce interventions. And so she just did a number of interviews at taxi stands, at bus stops, and with community leaders, and it's a pretty urban area. And she came upon these groups, they call themselves camps, and they're really naturally occurring. They, there's a structure, there's a chairman, there's a secretary, they pay membership dues, so there's a roster, they're somewhat organized, and there's many of them. And so she just thought, well, this is a great, okay, let's do an intervention. And she started thinking about, what are the causes of violence perpetration and HIV risk. And so that led her down the road of proposing a microfinance intervention with, loans and entrepreneurship training, trying to increase hope, trying to provide more opportunity, and then a peer health leader intervention. And I came on as my first year as a PhD student, right when she got her notice of award. And so right away, we were kind of thinking, okay, well, now we're going to do this thing. And so we started mapping the groups and the camps, and there was over 300 of them, and figuring out what the eligibility criteria was. And then we got these rosters. And so right away, we started thinking, well, these really are networks. And we didn't know yet what we wanted to do, but we were like, we should collect as much data as we can and try to do that as best we can. And so, we started reading up, and, for my first year, I was reading up, and we realized reducing burden would be important. So we, pre-programmed the rosters into a tablet, got them to identify who they knew, what types of relationships they had with each person in the camp, and then pick their 3 closest friends, and then asked a lot of questions about those friends. And then, so we kind of were collecting the data as we're thinking, well, what are we going to do with it? And trying to, keep up as best we could. And that really led to a number of opportunities for me to kind of, keep up thinking, okay, what additional data should we collect? What can we do with it? And so the few studies that I presented on kind of came to bear just after we had the data and realized how can we contribute to our understanding of network interventions. The first was looking at, the position of the network leaders within their networks and how that affected or was associated with their performance as peer health leaders. And we were really intrigued by this idea that their position and being really popular might inhibit their performance because of this pressure to conform with norms. And we were really asking them to talk about things that were not normative. And so even though we used a somewhat popular opinion leader approach to identify networks, we didn't use our network data that we collected to identify our peer leaders. We had folks nominate the 3 individuals in the camp that they thought best represented leadership qualities. And then we went from there. And there was actually a lot of variation in the peer health leader position. So when we hypothesized that those that were more popular would have be hindered in their performance, we actually did find support for that in their data, and those that were more bridging between with higher betweenness centrality would have better performance. We found some support for that as well. So that was consistent with our hypotheses, though still somewhat surprising, I think, because there really was a difference in the number of opportunities that those popular people had. They had more friends, they had more close friends, but they did report fewer conversations on the intervention topics that we were interested in. So that was the first thing. And then we had this interesting data on their perceptions of their best friends' HIV testing behavior. And then we had the best friend in the study too. So we had the actual data, and we could look at accuracy as well as bias. And so the bias being, when they're wrong, are they wrong in one direction or not? And one of the things we learned is that, oh gosh, accuracy is just off for everyone, which was like, they go to these camps every day. They are spending time there for hours a day. And this is for their one closest friend. And accuracy was like 60% for all. And then when we separated out by men who had tested before with those who hadn't, accuracy was pretty similar. But the bias was totally off for men who had not tested. And they just assumed all of their closest friend had not tested too, when in fact, half of them had tested for HIV. And so this just kind of pointed out an opportunity of, one, trying to increase communication and sharing and trying to change, norms and correct those misperceptions as an intervention strategy, which we did implement. We were still kind of having the intervention. And one of the effects when we finished the study was an increase in testing. So it's hard to tease out what led to that, but we did see in our intervention camps, there was an increase there. So that's the Tanzania side. I've shifted also to now doing a study in Cape Town, South Africa, where we're using a mobile app that was developed by Lisa Houtai-Weidman called Health Empowerment. And the network part of many features of the app is a forum where participants can talk with each other. They can also talk with peer leaders or youth advisory board members. The idea here is really to engage with each other, provide social support, connect, share experiences. And I've been adapting Health Empowerment to create an app specific for adolescents that are living with HIV in Cape Town, South Africa. So not too many changes to the structure of the app, mostly look and feel and a lot of content work. But the idea is that we're trying to position ourselves to be able to collect as much network data as we can from the forum to look at both engagement in the forum, what prompts active engagement, how does position and kind of their role in the network impact their experience in the intervention and potentially say something about their outcomes as well. So happy to take questions or share thoughts.
Awesome. It was so much fun to see the video and to see the breadth of things that you've covered between these two projects. And for those of you that I haven't had a chance to see it, I mean, the data collected is just remarkably rich, and to do it across, so many camps simultaneously and in another country, and asking questions that people don't necessarily like to answer. It's just an awesome testament to community buy-in and doing good work. So.
Yeah, I will say that we had, missing data is always a problem when you're collecting sociocentric network data of everybody on the rosters. So we then had to reach out to every single person who was, and then assess their eligibility, but then which were pretty relaxed, and then invite them to participate. And we had over 80% of the people identified on rosters ended up participating. And from the baseline to the 30-month assessment, our retention was still over 80%. So it was pretty complete, I think, relative, given the challenges for this type of work and the relative mobility in settings like Dar es Salaam, where there is a lot of movement and mobility. Our team on the ground just did an amazing job reaching out and creating trusting relationships with each of these 60 camp leaders and all their members.
Cool.
Marta, I was going to ask you, and you've, I think, maybe effectively answered this, but it sounds like you y'all really kind of enumerated everyone in the camp and tried to sort of catch everyone from a sampling perspective is what I'm curious about. So it was really to try, your goal was to catch everyone in the, okay.
It was. And, you know, these camps are mostly men, right? But actually there are some women that are members. And so that was another decision we had to make early on was, you know, the funding was all about men, right? They're over 80% of all camp members are men, but there are female, what are we going to do with them? And so as we were reading and learning about, you know, networks, we're like, no, we need to collect the data. And, you know, we will have to increase our sample to you know, allow for the data collection for women. Nina Yamanus is at American University, and she was involved in the formative work coming up to this. And then I think she was doing her postdoc, or maybe she had started her faculty position already, but she actually got some additional funding to support the data collection with the women, because we just felt like we wanted as complete as possible pictures of the network. So even data collection among women, even though they weren't, you know, a main focus, ended up being a priority for us as well.
Can you speak a little to the uptake of the Empower app and how you know, how that's like pragmatically going, and what your challenges have been? Totally.
So I'll tell you a little bit about it in the US and then in Cape Town. In the US, we're doing a 3-arm randomized control trial, and our target sample size is around 1,000 participants. It's nationwide. Data collection is all remote. So we advertise, meaning, you know, they're doing Qualtrics surveys. There's no face-to-face interaction with our research team. We advertise nationally. There are ads on Twitter, we've done Facebook, Grindr, Jack, they're all over. The target population really is men who have sex with men and trans women. And we have the 3 arms are actually interesting. So I'll tell you about related to uptake, but also just recruitments and design. So the PIs are Kate Messig at UNC and Jose Bauermeister at Penn. And they were really interested in, one, just having a more rigorous, you know, data on the effectiveness of health empowerment, or to information only version of the app. Okay, so that was one main interest. So we knew that those would be the 2 arms. But then they were also thinking, you know, it'd be really interesting to see if what the impact is of allowing peer referral and having participants be able to invite 2 friends to join the platform as well. How would that change everything, right? And so that was the intention. Unfortunately, there was a big, I think it's fair to say, flaw in the design, in that health empowerment is meant to be HIV status neutral. So we, in the intervention and the control, we have folks living with HIV and folks not living with HIV. And for some reason, I'm not sure why, the decision for the peer referral arm was to restrict it only to folks living with HIV. I did advocate strongly against this before we started, as did one of the other co-investigators, but we were outvoted. And so there's actually now a number of differences between the 3 arms. One is sample size. We don't have, when someone enrolls, you know, clicks on our ad, completes our screener, finds out they're eligible, if they're negative, they only get randomized to arms 1 or 2. If they're positive, they can get randomized to any of the 3 arms. And so we just have, you know, I think now we're maybe around 200 in arms 1, 200 in arm 2, but only 50 in arm 3. And surprisingly, and I say that kind of sarcastically, the peer referral hasn't really taken off. So we've had very limited peer referral. I think in the design, they thought, well, if folks, you know, if we have folks that are living with HIV in arm 3 and everybody identifies 2 friends, then, or maybe even 1 friend or what, then they'll all be similar sample sizes. But the peer referral has been a challenge. I think we're learning that, you know, some are referring and then the friends just aren't screening in. But for the most part, folks aren't even referring. But in general, I think the engagement with the platform is going well. Folks in general, it's a year-long study, and we're not seeing total drop-offs with people not using it all. The forum in arm 2, so that's the main intervention one, is very active. There are people who post frequently. There's lots of conversation. There's conversation about kind of intervention related topics like stigma and just challenges and coping and what have they experienced. So that's been really exciting to see. Arm 3's, forum engagement is not as good. And it's really hard to know if that's just because there's not enough people on there to really spur that conversation, if there's something else going on. I wish we had at least equal sizes, because I think will play a big role. On the South Africa side, we've so far only done small app testing. So we've done, an app testing with 12 participants. Their engagement was way higher than what we're seeing in the US. And I think it's just because access to this type of content is just not as readily available to them at their fingertips. They're also experiencing maybe I shouldn't do so much comparing, but their experiences of stigma are very high. They're often not disclosing to anybody about their status. And so this is a kind of unique opportunity for them to share and connect. We did notice that they weren't posting a lot in the forum, but they were going there like every day. So our plan for the pilot we're about to start is to make sure that our team is pushing something to the app every single day, so that there's at least something new, and hoping that we make it easier for them to engage.
Allison, do you have a question? There we go.
Sorry. Hi, I found your studies fascinating. I guess I'm wondering a more general question. When you're thinking about HIV and stigma, how do you think about engaging social networks when you're not necessarily open with your social networks? So how do we activate the social network when you haven't shared your status? And then also, do you feel like these online networks kind of solve that, or do they provide similar social support where you can be more anonymous, or is that
challenges? Our participants did tell us they really wanted a place where they could go for credible health information, that sometimes they didn't know what was right. They really liked that there would be, they liked that part of the app, that it would have credible information. It has come up some in our health empowerment platform. We do monitor extensively. So we have monitoring and checking in by our youth advisory members, and they're paid. We also have a pretty big team that is on every day and chatting, and we have care navigators. So we do some, we do link to other information. It hasn't really taken off and been a super big challenge for us, but we do monitor. I will say the other thing that's really come up for us is it does feel like a huge responsibility, especially us with working with adolescents and this population. We did have, this is not really related to your question about misinformation, but it is related to the question about monitoring. In our pilot, we had a young participant post a question, and it was, have any of you ever thought about killing yourselves because you're living with HIV? And I saw this on a Friday night, and I was like, oh my God. We have all these protocols for what to do when you're face to face, but we didn't really have good protocols for how we're going to respond. When am I supposed to wake up my coordinator in Cape Town? She's asleep. Oh my, we really need to have a better system for monitoring. And that has definitely prompted us to be much more clear about, what is the text we're going to put in the forum. One, hey, this is great. This person felt comfortable asking this question. Wait, we don't want to stigmatize asking, a question about mental health. This was there, so we want to celebrate that. So we came up with a post that will respond back that says, we're glad, we want Mossy to be a safe space, and we're glad you're asking this question. If you or someone does need help, these are the resources for you. And then we have a plan to kind of follow up just to check in, but making sure it's not too much. And it's been a lot to think about how we're going to respond. But I think we feel much better about our plans for the pilot now. Keith?
I'm wondering, what are you using for incentives, or are you using incentives? Because 80% response is remarkable, especially for now.
Yes, thanks for that. The incentives were pretty minimal. I'm trying to think. So in the Tanzania study, we did cash incentives for the baseline 12-month and 30-month assessment. We did a cash amount. I think it was like maybe $10 for the survey. Then there was an extra, I think $5 for providing, we were collecting blood and urine as well. So I think we did $5 maybe for each. I can't remember the total details. You know, we've thought a lot about what is generalizable and what isn't generalizable from this study, because some of it does seem really unique, right? The fact that these networks are so stable that 30 months later, they were, you know, intact enough. There was some movement around, new members joined, and but that 80% could still be retained. I have thought, you know, what is it about the camps themselves, their cohesion, their, you know, that allowed us to because I don't think it was the incentives. They were not, and there wasn't, I don't think, any incentive for the intervention beyond the intervention, content and training and support. Yeah.
Thank you.
Mm-hmm.
Great. Yami, I see you just joined. Thank you. Sorry for the confusion there.
No, I'm so sorry. I don't know. I apologize. You know, life.
No, we hear you. We're all still coming out of these things, and it was so great to see you there. We were just talking a bit about Marta's project, and wondered if maybe you wanted to share. It's a little bit of we can give you a chance to catch your feet here if you want, but just wanted to plan is just to you know, give people a quick overview of, you know, what you think is interesting or exciting or, you know, most important to think about in terms of your work on, you know, the spillover effects of the breast cancer studies or the other community engagement work you've been engaged with. So anyway, if you want to jump in now, we can do it, or we can give you a moment to get gathered and we'll continue on. So.
Sure, I'm happy to jump in. And just as an FYI, I'm so sorry about this, but I actually had a dental procedure. So if half of my face looks half of it is totally numb. I completely, just in all transparency. So yes, I think the thing that is most interesting about my work on spillover effects is just, I would say, highlighting or recognizing the twofold benefits of thinking about social networks in terms of intervention science and community engagement in general. The first one that I pushed, and I'm so sorry because I remember now with this recording, I had the audio recording and not the slides, so apologies there. But I think the first thing being that leadership or social networks can be used in terms of leadership training that can have some personal behavior effects for the ego themselves, which is really helpful over and beyond what we traditionally do with patient education. And then the second component being that network interventions, and this is a point to Tom Valenti's work just in general. So I've been really pushing this in terms of cancer equity work, but just noting that all interventions have possible network effects. They're just not consistently measured. And so I think really importantly, my work shows that any intervention has network effects that can be measurable a priori or post hoc, and that it's worth doing in order to get a really comprehensive estimate of how widely we're reaching folks. And those are the 2 points. I can talk a little bit about cost effectiveness, but I don't have to.
Awesome. I really enjoyed seeing the summary, and what it reminded me of was the fact that people often complain about the costs of interventions. Social interventions are costly, but the benefit is often much bigger than we think it is. I mean, the fact that you invest heavily in a navigation procedure to help one person, that person now has become sort of an ambassador for your program and a localized expert, and so you get this kind of multiplier effect for every dollar you put into an intensive contact. And you can imagine being a little smarter about how we do that. Randomly selecting people's intervention is probably fine. I mean, you get a lot of good folks, but if you could target some good bridges or some good stars or something, you might have a really effective program. I wonder if you thought about that kind of a targeting to actually exploit this much.
Sure. No, I have. I think I've been really pushing the broad span piece because I really want that personal behavior change effect, which has been really important. But I agree with you in terms of actual network outreach. You definitely want to have some targeted one to have broader reach of the population. I think what is interesting, actually, we're just wrapping up a paper that we're hoping to submit to Value in Health, this cost effectiveness paper. And we were kind of comparing like what happens with cost effectiveness when you only focus on egos or you only focus on the patients versus when you focus on patients and any network effects they might have. And what we actually see is that navigation is not cost effective when you only consider ego patients and you consider costs that are not just the intervention itself, but also the cost of the healthcare system in terms of mammography billing and all of that. However, once you include network effects, navigation then becomes cost effective, right? And so this is really interesting. I completely agree with you, Jim, in terms of, maybe targeted interventions might make it even more cost effective. I would say it'd be curious to see sort of targeted versus mass network intervention in terms of sort of seeing the breadth, right, of the folks you reach versus also the impact on the ego themselves, right? And so what we're seeing is that this kind of network intervention leads to more individuals obtaining screening themselves, which then promotes them to be more change agents, right? So it's one of those where it'd be curious to see those two approaches and just have some kind of quantifiable estimates from the cancer side of things, which I don't know that that's been done as much.
Other questions or thoughts for either of our speakers, of course. One of the bits that came up yesterday, I guess effectively it was a day, they're all blowing together for me now, or the day before yesterday, we had a fairly deep discussion on ethics that I had a lot of work to do about essentially what level of detail you give back either to reporting to the general population, like to the hospital system, for example, in the case of the cancer screening, or to the respondents themselves, like in the camps or in Power. Do you guys have thoughts on that, on both practical thoughts, what you have to do to get it through your IRBs, and substantive thoughts, like what's the right thing to do? Hope those shouldn't be different, of course, but just saying.
Jim, was the question mostly, I can share in general, but also about giving back, presenting back study findings and keeping, folks in, or just kind of really clearly communicating what the intentions are related to the network data collection pieces kind of on the front end?
Yeah, I was mainly thinking the second. I was assuming that the first was done, but yeah, you should talk about that as well. But I was really thinking about like in the camps, do you want to show people if their friendships are reciprocated? Do they ever see these, those kind of things, right?
Yeah. So we did have a lot of struggles about figuring out ourselves what are our steps, who do we need approval for, who do we need buy-in from. We went through kind of structured approaches of getting consent, even though it wasn't on consent forms, from community leaders before we approached the camps, and then got consent from the camp leader themselves to proceed with getting data collection. We thought we kind of got them to give their approval or consent to provide us with the camp rosters. That always felt a little bit gray for us, because our participants were not, or potential participants at that point, were not really giving individual consent to give us their names to be included on our roster. So the way we went around this, or the way our strategy for this, was to talk with the camp leaders to explain that this is research and we would like to be able to have everyone, consent to participate. We're trying to figure out a balancing act, because we can't reach everybody to get their permission to be on this roster in the first place. So why don't you have a meeting with your camp, see if they want to participate, see what the questions are, let us know if they have questions about what we're going to do with this data and with their information. Some did, some had questions about, what we were why we needed their phone numbers, and we explained what that was for. And for the most part, we didn't really have a lot of pushback at that point. And camp and most camp members were fine giving us their name and their phone number, even if they later told us they didn't want to participate. But that was one of the ethical issues. And that came up, I think that was a question in our Muimbili, our local IRB, was, you're getting all this information before consent. Do you really need it? And we had to explain why. Figuring out what to do with participants who stopped in the study, but were on our camp rosters was a challenge, especially if some of them moved. So we tried to work with the camp leader to say, is it okay to keep them as part of our network data collection? And usually they said, yeah, it's fine. Sometimes they reached out to the person, but if someone said themselves, I'm done, which I think only happened like 2 or 3 times, we did remove them from the roster because we felt like, it just didn't feel right to be asking such detailed questions about people's perceptions of that person when that person didn't want to be in the study. But that, yeah, it was a little bit unique, but thinking about, is it okay to ask questions about perceptions of someone when that someone was not in your study, it didn't consent to be in your study, I think was something our IRBs had not really grappled with before our study.
I'll go next. I think when I started right after being a fellow here, the IRB had no idea what to do with me whatsoever. But since then, I've actually seen some institutional change. I don't think just because of me, but now there's a whole boilerplate language around social network recruitment and around kind of what you need and how to go forth, which I think symbolizes that more and more folks, including other SNN fellows like Ashley Hughes from UIC, are just getting excellent training and are trying to use this type of work. The IRB has been mostly fine with me as long as I do not collect last name information if it's just purely network data collection efforts on the survey side of things. And then for network recruitment, I do a big emphasis around, I originally was compensating the intervention participants for recruiting their network members. And I am now working through not doing that because I do recognize that there is some coercion and, regardless of how easy it makes the study, it also does create an unsafe space. And so you can assess for coercion, you can emphasize that it's voluntary, but if money is involved, especially for vulnerable communities, it's a tough call and it's challenging. And I noticed this in particular with my R21 when I was working with Black women and their networks in kind of very underserved, economically disadvantaged parts of South Chicago, that the incentive really had potential to have negative ramifications. And so I've been pushing past that and just make it, it makes it less efficient, but also makes it more ethical and just more positive and a more safe space for everyone, I believe. I think the other thing to emphasize that has worked well for me is really framing the network data collection, the network recruitment in terms of leadership potential. And that has usually been a really good way for me to work and talk through what to participants, communicate why we're doing network-based work, is to emphasize that we're tracking what they're already doing naturally. And I think this is particularly helpful for me because I work, predominantly with Latina communities. And so in our communities, there's a big push on, and this is not monolithic, right? But there is this value or these customs around tight-knit networks and altruism and supporting others at the cost even of yourself. And so framing network related work in that context and through that cultural lens has made it more appealing, right? With the acknowledgement that, of course, we're not going to collect in-depth contact information unless the network member calls us directly to provide that information.
Okay, please.
Hi, thank you both for the really interesting presentations. I think there's like a million questions that could come out of this. I just had a very general, it's a bit of a strange thought, but I want to hear what you think about it, which is essentially, on a lot of these, the obvious sort of advantage to the spillover effect of one intervention into the community is things like, okay, so they actually had the mammography that they should have, had, or that is good for them to have, or they're getting information about HIV that is important for the future and things like that. But I can imagine the opposite happening as well, which is essentially people who are entering an intervention, their networks are transformed as well in ways that, and might change in a way that we know are good, are beneficial in general. So like being heavily embedded in particular relationships, having the sort of confidence to ask for help in particular communities, that in and of itself, like the transformative effect of an intervention on one's social networks, independent of sort of the outcome that we're looking at, may also have these really beneficial effects that we can't even think about. Like they're incalculable. So like moving people out of isolation is what I'm thinking of, for example. Is that part of the calculation being made on top of the sort of cost benefit calculation of like getting the correct medical procedure? Is the benefit of bringing people out of difficult social network positions into more beneficial social network positions calculated as well?
So I'll start, and you have raised excellent points for me because I think about them often, and I often have to battle with other folks around why I'm collecting the kind of data that I'm collecting. So thank you for the opportunity to vent about this because it's really helpful. I think one, exactly to what you're saying, there can be, of course, very beneficial impacts. It can also be not as beneficial impacts, right? And so, for example, if participants are dissatisfied, well, you've empowered them to talk about their dissatisfaction with the intervention and with mammography and to perpetuate that, right? And I think that's important to capture. I think this is where, and I push this because, my work in my entree and entrance into social networks was, of course, bolstered by this program, but before that was actually started by working with community health workers who said this is already happening. I talked to some people, they'll spread it out. I will always get referrals, no matter what, day or night. People will share that information with others, right? And so what I really value about network methods is that it allows us to quantify, right? Like what is the positive impact? What is the less positive impact, right, of dissemination? What are changes in all of that? And we can quantify that, see what's the prevalence and make adjustments in that way. I've been doing, or I should say I was working with Aditya Khanna, who's over at Duke University, who's an ancient-based modeler. And we actually originally were modeling navigation and its population effects and incorporating those, not negative, but let's say less trusting interactions around the healthcare system. And we're finding some really interesting effects wherein, based off of our empirical data, we saw a little bit more in terms of the positive effects, but definitely some of that was attenuated, right, by the negative effects. And we didn't get to explore it as much detail as we wanted to, but we did. To your other point, in terms of not just focusing on the outcomes, but also focusing on the nature of the network, this is something that has been really crucial to me. So I've been really fascinated not only with what gets disseminated and to whom it gets disseminated, but where it gets disseminated. With that context being that, if you think about how people talk to other people, right, that can have the potential for them to change how they conceptualize what a leader is, right? And so that's to say, a lot of times with these interventions, we think about those, top people who were born leaders, who were brokers, who just always did this, right? But leadership can look very different. And part of the interventions that I work on is really a customized intervention to showcase how anyone can disseminate work. And they can disseminate in whatever way that feels comfortable. They can pass out flyers and be an anonymous flyer passer. They can share messages via text, right? And all of that matters and is concrete. And I think just recognizing that leadership changes the self-efficacy to disseminate information, but also the self-efficacy to be in social interactions that they wouldn't necessarily have been in before, right? Again, with that nature being, it's up to you, and how you engage in socially really can vary and can be different. And there's not a right way to be social, right? And that's a big emphasis that we push on there. And then I'll just say that something I've been really curious that I keep getting curious comments about is, like I was saying before, I'm really particularly fascinated in public location. And so essentially when these people are disseminating work, are they doing it out on the streets? Are they doing it by phone call? Like how exactly are they interacting? Because I'm not only interested in spillover from the ego to, let's say, the priority altar, but also the spillover effects that might have community norm implications to them, right? So, por ejemplo, if you're out in the tiendita and you're hearing somebody else talking to another person about mammography, they're not talking to you about it directly, but you now suddenly have some information that apparently people are talking about this. That might lead to a change in the kind of values and the norms. And we haven't really done a great job of quantifying those norm changes, right? And how network interventions can have community level norm changes, at least in the cancer and community engagement world. So that's where I'm pushing through. I don't know if that was exactly where you wanted to go, but hopefully it was somewhere related or somewhere adjacent to it.
Yeah, this is appreciate the question and enjoyed hearing that perspective. This was something that our team thought a lot about. Are there unintended consequences to our intervention? Are we changing the network structure in a way that might be good or might be bad? And actually, Nina Yamanus, who I mentioned at American, she got a grant from the Fordham Ethics Institute. I think they have like a funding through for HIV, like ethics and for HIV and substance use. And she did a whole additional kind of study and data collection looking at the way that our intervention did change the structure of the network and potentially just create tensions. And one thing that her work found was that our creation or selection of these peer leaders did change the structure of these camps that, you know, had been, like I mentioned, pretty structured before. There had been a very clear chairperson, secretary, treasurer, and everybody else was members. And then now we didn't automatically pick the chairperson. That caused some tension. We picked 20% of these camps to be trained as peer leaders. And what we realized is that some of them, not abused, but used their power in ways that we didn't expect. And so they got involved in the microfinance part of our intervention and started becoming like gatekeepers and saying, no, you're not qualified. And sometimes it was good. They would say, this is too risky for you. You can't take a loan. You won't pay it back. But we didn't plan for that. We didn't expect them to take on this role, but by giving them this, title and training, they felt naturally kind of well positioned to serve in this kind of different role than they had before. And we thought about, is that okay? That wasn't our intention. What have we done? And so she did some qualitative interviews to try to dig into this more. And we tried to make sure we were looking at changes over time, and the network structure did change. They did in general become more cohesive, which I think we thought of as a good thing. But her research did point out some areas where, people might have been excluded by these new peer leaders from being able to access part of our intervention that we didn't quite anticipate.
Thanks for the answers. Yeah, that totally hit it. Thank you.
Tyler had to take his kids to school. All right. Other questions or comments on this? Like I said, if you haven't had a chance to go and review the videos, please do. They're just wonderful. And I'm a little bit, I feel like an old man. I always feel like an old man, but it's so great to see alumni of this program be so successful. And Marta and Yami have just like been superstars. And so it's just great to see this paying, thank you for joining in and paying this forward. And, thanks for being such great ambassadors for the program. It's really fantastic.
That's great. It was a pleasure. Definitely feel free to reach out if you guys have any questions or if we can be helpful in any way.
Absolutely. Thank you.
Let's go ahead and take 5 minutes and let folks get reset for the next session, and redo your coffee or grab a donut as you would. If we were back in Durham, we would have all that out for you on the table, but hopefully next year we can get together and have all that. So, all right, we'll reconvene at exactly 11 and start up with, I see that Ben and Ashton have joined us already. I don't know if Bria, good morning, Ben. Morning. Bria is on her way, so we will start again here in about 6 minutes or so.
Take care, everyone.
Take care. Thank you.